Very good evening, friends. Welcome back to Facebook Live Challenge by TAS. And after having a very good number of Facebook Live challenges on various topics, today we have this second presentation on medical research. The first one was given by Dr. Abhijit Nair, and uh, my understanding about problems in basic medical problem in the medical research is that we are stuck in a vicious cycle of can't and don't. We don't do medical research because we can't do, and we can't do medical research because we don't do. So to break this vicious cycle, I think it's very necessary to have some understanding of the basics of the research. And for that, today we have with us Dr. Rakesh Garg. He is an additional professor of anesthesiology and critical care and interventional pain in All India Institute of Medical Sciences, New Delhi. He has done his undergraduation from UCMS, New Delhi, and PG from Maulana Azad Medical College, New Delhi. He has some 390 publications. He has written to more than 20 chapters of the book. He has been editor of many of the journals. So I think he is the perfect person to teach us the basics of research. Thank you for joining us, sir. Over to you.
Thank you so much. Thank you, Dr. Nilesh, for giving this chance to interact with our own group of the Anesthetic Society. I think each member and all of you are doing wonderful work for the dissemination of knowledge through this Facebook platform. So I bring greetings from my center, All India Institute of Medical Sciences. Now, when we say the research, I think research is a fundamental thing. Sometimes when we discuss this topic, people believe that the research is only for researchers who have an interest in doing something new or a drug or a technique or something else. But my opinion would be that research is for everybody, whether he's a reader, whether he's a clinician or a researcher, because understanding research and bring it into your own clinical practice is equally important. Unless we know the basics of research, it will be too difficult to critically appraise a published paper. Like, for example, the ongoing COVID-19, which is there, but a lot of literature which is flooded into various journals. But is that all literature whichever is coming from various countries like China, US, Europe, in different patient profile, are they applicable to us? Can we apply the whole result to our population? It again requires understanding of the basics of research. So even for a clinician, understanding basic aspect is very, very important. And when we say the research which is being done at various aspects, you can probably divide them into a primary research and a secondary research. Primary research means performing the actual scientific studies based on some research question, based on some research problem, and that is intended to answer scientific questions. Like, for example, you want to know that whether hydroxychloroquine is is a good drug for prophylaxis of COVID-19. So it is a research problem. It's a research question. And if we can do a good randomized controlled trial and to look for some robust primary outcome, then it becomes a new knowledge. And that is what the primary research is. The secondary research means something has been published. For example, we have data related to COVID, which is already there in multiple formats across various countries. We need to know from those data whether something can be collated, something can be summarized from those existing literature, and that becomes the secondary research. And both the researches are equally important, because primary research will be from one authors, from maybe a group of authors from a particular institute, or maybe a multi-centering. But if it is from different parts of the country, different parts of the world, it gives a very global view, and then they can be put up into a form of something like say a systematic review or a meta-analysis or a pool data analysis, and that becomes a secondary research, and both are very, very important for the clinical science. Now, when we say primary research, it could be basic research, clinical research, and epidemiological research. Now, when we talk of the anesthesiologist, the critical care specialist, or we talk of the pain medicine, pain physician, most of the time we are concerned about the clinical research, but a little bit of basic research, because some of us will be interested to think of what can come out of the basic research. It could be a theoretical aspect in which we are looking for something new that comes up. For example, we want to look for some brain imaging that could be useful for identifying some new tool for assessing the sedation, assessing the depth of anesthesia. So those would be a basic research where we are looking for the various centers in the brain that are related to some changes with the external stimulus. So that is what we are doing for this type of basic research. If you want to have the applied application of the basic research, we go ahead and do it on animal models, or we'll take out some genetic material and do it. Like we want to say why some patients are having, say, COVID mild and somebody is having a severe condition. Is it some genetic relation? Is some change in the genetic sequences? And that is what we are looking for. Similar would be the various biomarkers or the biochemical agents that needs to be looked for, and then we can develop something which will be helping us. So these are the research sometimes which are under the umbrella of basic research. Majority of time we are into the clinical research field, which could be an experimental or interventional, and the other could be the observational studies. And majority of experimental studies are usually clinical studies, and majority of time when we want some robust outcome, meaningful outcome with some known research question, we say it's a randomized controlled trial what we are looking for. But at times we are looking for the observational studies also, which could be therapeutic, prognostic, diagnostic, drug studies, or secondary data analysis, or maybe sometimes case series also. So these comes into the preview of the observational studies. When we say the epidemiological research, which is usually a field survey, it could be an experimental wherein we intervene. Maybe like, for example, we want to give some counseling of hand hygiene or wearing a proper mask into the field, into some village or into some specific area. It becomes an intervention. But on the other hand, there could be that we want to observe the perception of persons wearing mask in COVID-19. It becomes an observational study and could be cohort, case control, cross-sectional, depending upon the direction in which our research goes on. So based on this, we say that the observational research is happening. Now, coming to the secondary research, I said this is again very important for understanding the multitude of data which comes across countries and across the globe, and that needs to be summarized into a simpler format, and that becomes a systematic review. Now, this review is different from narrative review, wherein the author's perception could be there, but in a systematic review, the author's perception is not there. Actually, they see for the data in a systematic format across the published literature and try to summarize them in some meaningful conclusion. And if it has some type of the quantitative data that needs to be assessed, then obviously we go ahead and do a meta-analysis for these group of studies also, and that gives very many meaningful technique A is better than technique B, or the study group drug A is better than the drug B. So that is how the meta-analysis from multiple of data will be a very helpful source for making when we say the guidelines or the clinical advisories or the clinical practice patterns. So this is what we come up with concrete outcome, and that is how the guidelines and all those things are made. Now let's see this research process. This is very important to understand that how actually the research process happens, and each step, each part is very, very important. The first is when we think of some clinical problem that, say, for example, I'm working in an operation theater. I think I'm thinking that, say, my drug is being used for some particular process, but it is not giving benefit. It has some adverse effect. So I'm thinking of it's a clinical problem for me. So let me do a review of literature to look for whether it's actually with me, my practice, or it is across the globe. That is what we require a review of literature, which is again a scientific step. And based on this, we formulate a research question from a clinical problem. Once the research question is formed, we select an appropriate research design. This is again very important. This is very important topic, because to answer a research question, unless we choose an appropriate research design, the outcome may not be acceptable. The study will be rejected by the editors also. Once our research design is there, we start doing the studies, have proper methodology, collect the relevant data, and try to analyze data to have our findings and try to interpret them scientifically. And once it is done, the published literature is being done. And this published findings will be again used by subsequent researchers for some new finding, which could have been the limitation into our study. Or maybe a secondary research, which I mentioned earlier, could be a systematic review and or meta-analysis. So this is how the whole process of research is being undertaken. And each step is very, very important, because if you don't follow these steps, the chances of the acceptability of research by readers will be much less. On the other hand, even it will not be even published if the whole steps have not been done into a proper format. So I'll take you through all those steps in a very basic way, though it's a very big topic. It's a sometimes a 1 day research or maybe a 3 day research research workshop, but I try to give you a key points in next half an hour to 45 minutes. Now, the first thing is when we want to do a research, we need to identify the problem, the clinical problem. And this is the very, very important step, because we are looking for some novelty. We are looking for some clinical translation of the research we are going to do. And that clinical translation will only be there when we have some problem. And this problem should be appropriately researched or have a proper review of literature. And the sources could be many. It could be theoretical basis. If I say that the drug A on a theoretical basis, because it acts on a particular receptor, may not be very good analgesic, but those drugs which acts on the other receptors, peripheral mu receptors, will have better analgesia. So with that theoretical basis, you can say this molecule appears to be better because it acts on extra spinal cord mu receptors and has probably better analgesia when we go ahead and do, say, a facial pain block, or we do a peripheral blocks where we inject the drugs and look for whether the opiates has some effect. So those could be theoretical basis. The professional practice or the personal experience, when you say you are using a technique, it is not giving you much outcome to your satisfaction, or patients are not satisfied, or adverse effect are much more, you start thinking of something new and you start practicing it. And you find that something is coming better. Is it really better, or it is your perception? It requires a research, or sometimes a sheer curiosity. For example, in COVID-19, when we're talking of how can we prevent the aerosol generation effect on the person who are managing the airway. So people were thinking of, it was sheer curiosity that can we stop it? Yes, we can stop it. People start wearing N95 masks. People start wearing the goggles. They start having the face shield. But still, they were exposed to aerosol. So they were looking for something new, and then comes out with the intubation box or the aerosol containment box, which have some improvements subsequently with negative section. So this means the curiosity of a clinical problem, that how can we do better, identifies a problem. And this is the basic crux, that when we want to do a study, don't copycat from somebody. Think that, is there some problem in the clinical practice, either from your own or from some others, or from the review of literature. And that is what you require, review of literature. What, why, and where. What means you should have a specific focused clinical problem, and based on this you need to do it. Then only you can think of, have somebody done it earlier? Is this already well known to anybody, or we are just doing practice which we are not aware of? So this is how you do a review of literature, and you know exactly that this problem is not only with your clinical practice, but exists other places also, and that needs to be researched. And from where to do it? Now, the review of literature always should be done from a source which is very reliable. And when we say reliable means it has been published into a system, into an engine which is well controlled. Well controlled, I means somebody has peer reviewed it, somebody has authenticated it, somebody has checked that it is in a proper format, and then it will be published. And that's why we have to look for a robust source. And this is something like this, a PubMed, which is usually with peer-reviewed publications. So this means you can authenticate it. Similarly, you can think of Cochrane Library. Even to a certain extent, the Google Scholar could be one of the other options. Scopus is one of the good options. So these are the reliable libraries or reliable search engine places where you can have a good quality paper you can review to find a clinical problem. Sometimes people do ask, is a Google search good? Because majority of time we are so fancy about Google, we put up something and try to search it. But Google itself is not a good source for the review of literature, because anything and everything can be published on Google, and you will not be knowing that whether it has been peer reviewed by the experts or not. So try to avoid Google. You can go ahead and do a PubMed search, a Scopus search, or a Cochrane library, and these are the good libraries where you can get good articles for review of literature. So once you have a review of literature and you approach a clinical problem into it, then you have to formulate a research question. And that's the first step of the starting of the research. And this is very, very important. Having said that, research question is a small word, but it has a lot of things. You will see in a couple of slides which are forthcoming, that every clinical research project start with a practice, or it is a quest for newer practice. And that is what it should be, very well defined. It should have some basic components that gives you an entity that this is what you are going to do. And that should be very, very crystal clear. And that's why a research question needs to have very clear components and a clinical that would be helpful for your clinical improvement. So we have to turn the clinical problem into a research question. And as I mentioned of the clinical problem here, again, research question needs some refinement, and that is based on previous research, new ideas, your clinical observation, your clinical discussion with your peer groups like grant rounds, case rounds, teaching, or variability in the clinical practice. Now, why this question is important? Because this will help you to identify your objectives for writing a protocol. It will help you to choose a study design. I mentioned there are so many study design. How can we choose for case control versus RCT versus observational, or a retrospective versus prospective studies? So the choice of study design also depends upon a well-defined research question, and helps you in the analysis and decision making by appropriate statistical tools. And once you have a well-defined research question, because as an editor, when we see some study, we first want to know whether a proper research question has been developed by the authors, and based on this subsequent things has been done. So it ensures a better chance of publication. Getting a right question increases the likelihood of finding a correct solution to the problem. So this is the crux here. Unless we identify that what should be the components of research question, will not be able to set a method. If methods are not correct, results will not be correct. If results are not correct, our interpretation will be wrong. So this is the whole crux. So we need to spend a lot of time on the research question, but to our experience, most of us will spend a very little time on the research question, but subsequently more on discussion. And that is how we don't get our publications into good journal. Moreover, with the quest of finding things, we look for some clinical problem and try to identify many research questions at one point of time. Now, this is a word of caution here. So when we do a research, try to identify a single problem. Try to translate that single clinical problem into a single primary research question. And that is very important, because otherwise your analysis becomes too complicated. Your sample size calculation becomes too complicated. So have a single primary research question for your study. Maybe sometimes you are thinking of that you have looked for the efficacy of some drug or some technique or some newer block, and you are looking for the adverse effect also. Now, this is an important one. So you can put up some important secondary questions here, which will be helping you to analyze the primary question. But the main question, the primary research question, usually nowadays should be only one that will be helping for your good study design, good analysis, and good conduct of a study. Now, having said that, now I'm coming to the important aspect once again with regards to the research question. What or how the research question should be there. Now, when we say the research question, you should look for this mnemonic, the final criteria. Now, this is very, very important. When we say the research question, I said, it has some clinical value, it should be publishable. So who and how will be published? If you follow this criteria, the chances of its usefulness will be much higher. The finer means feasible, interesting, novel, ethical, and relevant. What I mean feasible is, when we start thinking of a study, the technique, the tools, the resources, the staff and manpower should be available to me. For example, say I am thinking of, say, are there some electron microscopic changes in a patient who suffers from COVID-19 in the lung endothelium? Now, when we say this, there should be some resources who can take a biopsy. There should be availability of electron microscopy. So this means the feasibility of the various tools and techniques that you use into a study must be available. Interesting. It should be interesting to a researcher collaborator. It should be my interest. If somebody says, you do a research which is of not much interest, I will not show much interest into the conduct. And that's why the outcome may not be so good. There may be a loss of patients, loss to follow-up of a patient, or data may be missing. So any researchers, whenever they want to do a study, they should have a topic which is interesting to them. The N stands for novelty. Now this is important because we are not going to do a study which we know, which is already proven. We know that dexmedetomidine is a good sedative agent, it can be used. So why do we want to look for the efficacy of dexmedetomidine versus propofol for sedation efficacy? So this is, I mean, when we start doing something, we should look for, are we going to get something new outcome from this study? Or if there is some contradictory statement, some says that this is good, some say this is bad or not useful, that you can think of. So this means that whatever your primary research question is, it should have novelty and it should follow the ethical norms that the patient volunteers or the patient's group that you are including, they should be ethically and follow the ethical guidelines. And the relevant to the scientific knowledge, it has some clinical translation value, and it will be helping to form some guidelines or the health policies. So that should be fitting your final criteria. If yes, then start thinking of that this is a good research question and we can go ahead. Once you are confirmed that it is the finer is fitting into it, now let's put a complete research question. Now there should be certain components of research question here. And this research question, when we say the components, this mnemonic is very useful of PICO. Now PICO means that any research question must have these 5 components, and then only we say it's a complete research question. This is very, very important because many of the times we forget to write either of the components and the study gets the study is not published because we have not defined them a priori. P stands for the study population. I stand for the intervention that you want to done, maybe a drug trial, maybe a new drug, maybe a drug with different dose, maybe a pain block. The C stands for the control arm. So whenever you want to say that A is better than B, so there should be some gold standard or there should be some standard of care, and that is what is called as control arm. We should be clear about the outcome, and T stands for timing of measurement of outcome. So this is what needs to be clarified in your research question, and this is very, very important when you start with. Let me give you some examples here. When we say patient, P, patient population, you should clarify whether it's infants, whether it's 18 to 45 years, 18 to 60 years, more than 60 years, the gender, the type of patients, for example, all adult patients undergoing laparoscopic surgeries, laparoscopic thoracic surgeries. So this population should be defined a priori when you are formulating a research question. The interventions, you should define the drug, maybe any drug that you want to use, any technique or any different dosages of a drug that needs to be defined. Now, control is important here because you want to compare to say this is better, this is equivalent, or this is not inferior to technique. Now, whom to compare? Ideal will be if you have something gold standard, right? For example, we say that the gold standard for airway management in a difficult airway is using awake fiber optic intubation or of use of fiber optic intubation. So we have some gold standard available. Similarly, would be a gold standard drug that needs to be used for patients who require anesthesia. There would be gold standard drugs for blocks like local anesthetic agents. So at times we'll have gold standard, but sometimes they may not be gold standard. For example, when I talk of local anesthetic agents, is bupivacaine better than lignocaine or bupivacaine better than ropivacaine? Is there some gold standard? It will be too difficult to say. In that situation, we need to use the standard of care or the conventional technique that we are using here. Sometimes we use placebo, but we should be very cautious when we say the placebo techniques, because the patient during a research should not be devoid of a standard of care. For example, I want to see the analgesic effect of a different block. This means I should not be dividing one group of patients from giving analgesic agents. So this is not right. This is unethical. So I will not be using placebo here. One patient with some analgesic drug, other patient no analgesic drug, this will be unethical. So what I will be doing is, obviously one new technique or new drug, but the other I will be using either a gold standard or a standard of care, and that is very, very important to understand when we start an RCT. The outcome should be clear, that what are you going to observe for these patients, the heart rate, the complications, the analgesia effect, the sedation efficacy, whatever, and the time of measurement. This is again very, very important. For example, I say that how much would be the post-operative nausea, vomiting after a specific anesthetic technique. Now, it doesn't mean that some people can measure it for 2 hours, some for 12 hours, for 24 hours. So maybe when we say 2 hours, probably no vomiting, but 12 hours, yes, they could be vomiting. For 24 hours, if you are using a short-acting agents, obviously there will be a nausea and vomiting. But if you define that the patients with this technique will have how much of nausea, vomiting in 24 hours or 12 hours, or analgesia, analgesic requirement in first 24 hours. So this time definition should also be there in your research question. So this means if you use a PICO technique, it enhances the clarity of thought process in developing the protocol. It helps you to choose a proper design. It helps you to analyze your decisions properly. And definitely all of us want, when we do a research, we want its publication. If the research question is good, if the research question is having all the PICO components, the chances of publication is much, much higher, because the quality would improve upon. So that needs to be taken care of when you plan a research question. The research question could be based on anything. It could be intervention, it could be therapy, prognosis, diagnosis, whatever it is. You can choose any research question, but it should have all the components of PICO. Let's see this example. Now, I think this appears to be a complete research question. In adult patients undergoing elective surgery, does treatment with epidural analgesia in combination with acetaminophen and NSAIDs, that is multimodal analgesia, compared with epidural alone, single model, lead to better pain relief and less side effects over 24 hours following surgery? I think this appears to be, so I'll just wait for half a minute for you. If you all can just think of where it is PICOT are there, P-I-C-O-T in this research question. I'll just give you around 15 to 20 seconds to think of, and I'll then proceed with the next slide. Right. I'm sure you must have thought of. Probably it appears to be a complete. So let's see. So these are the various PICOT components, and that should be there in research question. So we can now retrospect that when we have done our studies, do we have complete set of information? So when we say the adult patients undergoing elective surgeries, this is what is P here. The intervention was epidural analgesia in combination with acetaminophen and NSAID, that is the multimodal analgesia. I was comparing with epidural alone, probably maybe a standard of care. The outcome was pain relief, and the time frame was 24 hours following surgery. So this means the whole PICOT is into this research question. So whenever you plan further research, ensure that you should be clear. Now, in case if I would have mentioned in adult patients, does treatment with epidural analgesia, if we say elective versus emergency surgery, the pain management would be different, and the choice of drugs would be different. That's why we can define the elective surgery here. So this means your each PICOT component should be defined appropriately so that it gives you a good outcome in the form of analysis. Now, when we say the same research question, I said two things. One is the PICO, and the second was the FINER. Let's see the FINER. Is it feasible? Yes, I have a lot of patients. It is clinical relevance to me. It's interesting because I want to provide better pain relief to my patients. And I said, probably if you think something has not been published, it becomes novel. Ethical, I think there is nothing wrong about it. Relevant, yes, it is clinical to my clinical practice because I do a lot of laparotomies where patients do require analgesia, they do require pain relief, so it is relevant to my clinical practice as such. And some of my patients do complain of pain, so I want to give them a good pain relief. That's why this multimodal analgesia in my setup would be good. This is probably fitting into a finer criteria and PICO, so I think we can go ahead and do this research. Now, once this has been done, the research question has been prepared, we have to think of what should be the focused aim and objective for this study. And that is, we can think of based on the research question we have developed, because now this is a stepwise approach. So we had a clinical problem, we do a review of literature, we reached a research question. Now let's develop aims and objective because we want to do a study now. Now, when we say a research question turning into an objective, aim and objectives, look for the objectives here. Now, the objectives could be primary and secondary. I always mention that nowadays we should not be looking for many primary objectives. Anything which is of greatest interest should be a single primary objective for this question and consider its feasibility also. Secondary is when we think of something which is associated to a primary objective, is of some clinical relevance to say that this drug is better than drug B, but you're worried about some side effect, so this is a relevance one. So you can put it as a secondary objective. But usually there should be one primary objective or maybe one or two secondary objectives. So don't try to put much because it increases the complexity of surgery and interpretation becomes too difficult and outcome becomes unreliable. So that's why just don't go for multiple of primary objectives in this time. So when we say the objectives, again, your objective should be fitting this mnemonic. I'm giving you three mnemonics here, the SMART. Now, when we say objectives, it should be specific. This is very, very important. It should not be a very broader term that we are looking for analgesic efficacy. Analgesic efficacy with regards to what? In what duration? So it should be specific. It should be measurable. You should have some preferably objective tool for measuring it. But if not, at least some reliable quantitative tool may be there for measuring it. It should be attainable. It should be relevant to a clinical practice and time frame. For example, if I want to say you want to observe for some adverse effect, but you know that that adverse effect will be manifested in 30 years or 40 years. So the time frame, I mean 30, 40 years for a particular side effect may not be so good. It may be good for some other genetic studies. So this means the time frame should be sufficient so that you are able to measure that side effect into the time frame of your study. So that's why this SMART again comes into your framing of objectives, and that becomes important. When we say the aims and objectives, they translate into outcomes now. So I said that each step is interrelated in the method section. So you have an objective clear, and then try to translate into your outcomes. That's what you are going to measure. So it should be a meaningful endpoint as a primary outcome. It should be sensitive to the effect of treatment. It should influence physician decisions, and it also determines sample size. So for example, you want to look for the analgesic efficacy or the prolongation of analgesia for a particular technique A versus technique B. Then you have to think of what you're looking for. Your pain. For pain, you need to look for some good tool. Maybe mild, moderate, severe pain. No, this is not good because it has a lot of it lacks objectivity. So let's think of some more objective. Yes, we can think of VAS. We can think of numerical rating scale, or we can think of some multidimensional tools like pain questionnaires. So they have a very robust, specific endpoint, and they are sensitive to the effect of treatment because you're comparing the effect of two different techniques on analgesia, and that is the pain, and we can look for by this using this tool. This is how you can be able to specify a primary outcome. It should be very clear. So this means if you give an example, our primary outcome variable is pain. Do you think this is okay if the study is effect of epidural block after LSCS? Probably not, because we have not defined it clearly. So our primary outcome variable should be pain as measured by WASP on a scale of 1 to 100, and it will be good if I can say in a time frame of say first 12 hours or first 24 hours. So this is what you need to define into your primary outcomes. Now, similar to the objectives, we say they determine the impact of pregabalin in patients undergoing abdominal surgery. So this type of objectives again will not be complete. It is imprecise. Probably the good objective here would be to determine the analgesic efficacy of single dose of oral pregabalin, because we know that dose affects the outcome as compared to placebo. So we are classifying the compare because pregabalin is not routinely used, so placebo is allowed. Administered 2 hours prior to surgery in adult patients undergoing laparoscopic abdominal surgery under general anesthesia. So this means your objective should be very crystal clear, and it should have all the components that does not leave ambiguity. And this is what we are looking for. So till this point, we are saying that we are looking for a good clinical research question with predefined aims and objective, and you should follow SMART, FINER, and PICO. Now let's go to the next sessions of methods. Now methods is equally important. We have a research question now. Now let's translate into a doable format, and this is what is methodology. It should be replicable. It assures that a hypothesis will be proved. Each part, how you are going to do it, should be replicated into the method section. A proper study design, location of the study period should also be there, because at times the drug changes, the applicability decreases, the permissions of using a drug, sometimes they are taken out of the market. So that's why the study period should be mentioned. The selection of study subjects should be very defined. Who are the inclusion criteria? Who are the exclusion criteria? I just want to add here that exclude only those patients who have been included into a study. Sometimes we see that our study will include, and the inclusion criteria would be study includes patients from 18 to 60 years of age. But then we say patient less than 18 years and more than 60 years are excluded. This is not right. Only from those patients which you have included, that is 18 to 60 years, from this group only you can exclude. Since you have not included less than 18 years, so you should not be excluding those patients. So what I meant to say is, whatever the inclusion criteria are, from those patients, if you think there are some confounders, if you think some needs to be excluded, only from those you can remove those patients. And it should be very clear that at what point of time you can exclude the patients or they can discontinue the interventions. That should be clear in your method section. You should have robust planning for data collection, compilation, data cleaning, and analysis planning a priori. Sometimes we say the data analysis will be done as desired after the study. No, this may not be right. You should be clear that you will be comparing this with this using this type of statistical tool. You will be looking for the normality of data, and accordingly you will be using those data. Also, you should be very clear about the study tools, terminologies, orientation of drawings. Tools, I mean, if you want to use some questionnaire, if you want to measure some measurement tool, they should be very clearly defined. For example, if you want to do a BP measurement, so you should be clear whether you'll be using non-invasive blood pressure or an invasive blood pressure. Even for non-invasive, you want to see whether you'll be using a sphygmomanometer or an automated manometer. At what point, whether in a supine position or a sitting position. So this means the study tools should be defined appropriately and as the terminologies also. So this should be very clear, and the data collection tool should be ready so that you are not missing any data. The instrument tools, as I mentioned, they should be cited properly. The tool should be validated one, or they should be standardized test or standardized tools, and that is very, very important for the validity of your outcomes, validity of your data that you have collected from these methods. You should also mention how, when, and where the observations should be made. For example, you say patient will be looked for pain management in the post-operative period. So you should be clear that in the post-operative anesthesia ward for the first 24 hours, patient will be monitored and pain will be measured or observed using NRS scale hourly or 2 hourly. So this means this description must be there in method section, and same would be applicable for clinical examinations, laboratory tests, or a questionnaire or interview. You should be very cautious about the confidentiality and the ethical approvals from your institutes, and that is very, very important. Now, coming to the sampling technique, we have decided the patient's inclusion and exclusion criteria. We need to sample. The best study would be if you include all the patients, all the persons, and then you'll be absolutely sure that this is true, but that is not ethical. Now, what we do is we sample, we select a group of people from a larger population and then extrapolate it. If we select a wrong population, or if our selection is biased, then we cannot extrapolate our outcomes to the whole population. So that's why the sampling is important, so as to give equal chance to each individual to participate in the study. And this is what is important is. And this is can create bias if we are not very cautious about it. Similarly, the sample size should be adequate. Too small, which will not have a valid difference, will not be able to do some robust analysis to say that this is true. The outcome may be unreliable. If a large size, it will be time consuming, uneconomical. At times, we say it's unethical also. If we can prove that this difference in drug A and drug B can be done effectively in 100 patients, why should I expose 200 patients just to have large size? So we should be very, very clear. Samplings, we use probability or random sampling and non-probability or sampling also. Now, for a good RCT, for a good study, usually the random sampling is good because it avoids bias. Sometimes we use non-probability samples also, but this is usually restricted for studies. For example, you want to look for patients with some genetic disorders. So we'll not be getting too many patients, so you cannot randomize them. In those situations, you can use non-probability samples. But the probability samples always are the gold standards because you can generalize. There are less chances of bias, and your statistical significance is much more proven with this type of samplings as compared to the non-random samplings. Probability samplers depends upon the type or design of a study. It could be simple random, or sometimes we need to stratify them. For example, if your outcomes may be affected by young age versus the elderly age, and you have included 18 to 60 years, you can stratify them between 18 to 45 and 45 to 60, so that you have a comparable number of people in the two groups. So we need to have a target population. We do a study population and then pick up study sample for it. And finally, we randomize them into groups as per our requirement. So why do we need a control group? I said in the PICO, we need a control group and how to allocate patients in these groups. Now, it has been seen that sometimes there is some called placebo effect. So placebo effect could be seen in the study group. It could be in the experimental group. So we do not know what type of effect it is. A patient who is admitted in hospital can have placebo effect if a clinician talks them very nicely, reassures them. So there will be some cooling and calming effect or anxiolysis effect by a researcher, and we want to balance in the two groups. So that is why to avoid this placebo effect, we insert something called control group here so that we can compare it. Sometimes placebo, as I mentioned in the beginning, is not possible. We cannot avoid not giving analgesia for the purpose of control. We can use this standard of care or a low dose group or a gold standard. So this is how we stack controls. Historical controls, sometimes we can think of wherein we are not getting some studies, some interventions which were not acceptable now, but they were acceptable in the previous days. Some drug has been banned and we want to see whether there is some effect of this drug, then we can use historical controls. But if the things are being used even today, we should avoid using historical controls. So once we have sampled our population, we need to randomize them. Randomization is basically to enable a fair and unbiased comparison of the study group. Because if we do not randomize them, we can choose any patients into either group, and the chances of bias will be there. How can we do it? The treatment which is being allocated is unpredictable to both the investigator and the patient. That is the best thing. And that leads to the equal distribution of many known and unknown factors. In the inclusion-exclusion criteria, we have thought of some inclusion and exclusion, but there would be so many other factors which we do not know, and we want to balance them into two groups equally, and that is what the randomization does for it. It balances the various factors, it simplifies the things, and we can do it in various formats, which I've just mentioned. We can use manual methods like tossing coins or cheat paste, but nowadays we are using either a random number table or we use computer-generated random number tables that helps us to randomize to different groups using date of birth or date of presentation or alternate assignment. These needs to be avoided because they can create bias. We can use simple random number table, or maybe you can use computer-generated. Once we have randomized it, still we know that this patient is going into this group. So what we need to do is allocation concealment. If we have the sequence of randomization, we still not. We need to hide it because we can create a selection bias. And we can do it by doing something called allocation concealment. This means once the person has been randomized, he should be concealed from the researcher before the recruitment of the patient. Only once the patient has been recruited into a study, you know that now this has been entered into a study, then only you should know whether this will receive group drug A or drug B. So this means proper allocation concealment shields the knowledge of forthcoming assignment, whereas proper randomized sequence generates prevent correct anticipation of future assignment. So these are the two important components that must be taken care of when you think of randomization along with allocation concealment. And you can use any of these methods. Most commonly we use the snooze technique, sequentially numbered opaque sealed envelope technique, where the randomized numbers are written on a chit. They are kept in these sealed envelopes which are opaque and they are numbered. So you open once a patient is recruited and then you follow it. Equally important will be blinding, because if you are doing something and you know that the drug has been given to this patient, you can create bias. And that is a very good practice, that you blind whatever possible. We have open trial where we are not able to mask or blind the things, but single blind, double blind, triple blind, these were the terminologies which were being used. But better would be blind as many as individuals as possible in the trial. So if you have multiple interventions, multiple people, multiple steps, try to blind everything. And your method section must describe that who has been blinded and how it has been blinded. So that will give you a best unbiased outcome, and that is possible. In case if it is not possible, because if you want to say the intubation success rate using video laryngoscope versus fiber optic bronchoscope, obviously you know that equipment is happening, you'll not be able to blind it. In those situations, try to use the measurement tool in such a way that the bias cannot be there. For example, you want to say the time difference of securing the airway using these two tools, you can use a stopwatch. You can do a video recording and somebody else can measure the exact time. So this is how you can create objectivity so that the blinding is maintained, and or the standardize a treatment as large as possible, so that or maybe the repeated readings. So that is how you can avoid having some bias for not blinding in these group of studies. The other thing is the bias and confinders. Now, these are important things because your outcome will be affected. It could be reading literature or for analyzing data and so on and so forth. So you should be cautious about these things. The bias could be in selection when there is an imbalance in baseline characteristics, or there will be more number of loss or to follow up in a particular group. So that bias can be there. Maybe those are more sicker patients or they were not satisfied. That's why they were lost to follow up, and that can create a selection bias. Measurement bias. If you are using a sphygmomanometer for BP measurement, it could be your measurement bias can come into it. So you have to objectify that this reading, this Korotkov sounds 3 readings, minimal of readings or average of readings, should be clear. Recall bias, specifically when you're asking you how much sense of nausea, vomiting you had in the last 24 hours, it will be issue. Maybe if a patient is under follow-up and you say in the last 15 days, how much was the pain score on the day 1, patient may not recall the events. So these type of bias should be taken care of. Observer bias, as I mentioned about the BP measurements. Similar will be issue of confounding. Confounding, I means if there is something which can affect your exposure and outcome, right? That becomes an issue. For example, you're looking for some study, the coffee consumption versus pancreatic cancer, and you believe that increased coffee consumption increases the pancreatic cancer. But now, if there is a factor which can affect the coffee consumption, which can affect the pancreatic cancer, that becomes a confounder. And for example, is smoking. It has been seen that those who smokes probably has more coffee consumption. Also, those who smokes have a pancreatic cancer. So now this is what the confounder is. So when you plan a study, either you exclude this group of patients or you try to include them appropriately in 2 groups so that your outcomes are not affected. Now, coming to the research and statistics is a big topic, but I'll try to summarize it so that it becomes easy for you. We are not statisticians, so try to consult a person who is expertise into statistics from the beginning of this. Don't say once the data will be collected, we'll drop them in. Try to include from the protocol formulation itself so that they can help you. They can help you in the sample size calculation, and they will help you to look for various variables and the study designs once you include from the beginning itself. So this is what is required for sample size calculation. You should be aware of what type of variables are using. Variables, I mean the outcome variables. What type of study designs you are using, and based on this, you can think of what should be the power, what should be the confidence interval, what should be the effect size. So these are the prerequisites that are required for sample size. And when you go to the statistician for calculating sample size, ensure that these things are available to you for proper sample size calculation, and then only you can get a good sample size. So this means when you have to have a sample size calculation, you should think of level of significance. Usually we keep it at 0.05. You need to know the power of your study. Usually we assume it to be 80%, but sometimes we can go for 90% also. The effect size, that is to detect a smaller difference from your two groups. That effect size should be clear based on either your experience or based on the review of literature. And this will help you to look for the sample size, which can be calculated using formulas. But nowadays we use various computer-based software tools, and that will be helping you to sample size calculation. Now, when we say talk of the power and this the type of errors, usually we say there are two types of errors that we see in the research. Type 1, where we find a difference in treatment when actually there is no difference, and we say it's false positive. And type 2, where we fail to find a difference when actually there is a difference, and this is called false negative, and this is also called beta. Now, power is 1 minus beta that we use for power. So we can say type 2 error up to 20% is acceptable to us, or we say power is 80%. When we say type 1 error, we cannot be 100% error free. So we have to assume that some type of error will be acceptable. And we say that the type 1 error or alpha of 5% is acceptable. And that is why we keep a level of significance as 0.05. So these are the significance. When I say p-value of 0.05, we have kept power of 80% for sample size calculation. So that needs to be taken care of. So this is how we do a hypothesis test, and we have already discussed about the type 2 and the type 1 error here, and this is we have talked about the power here. Now coming to the variables. Now when we define any variable, we use a lot of variables, which could be age, hemoglobin, but remember one thing, whatever you use variables, they should be very clearly defined. Say for example, age. So it should be mentioned at age at last birthday. Maybe a person is 4 years, 11 months, they will say 5 years. So you should be very, very clear that each variable must be defined in an objective way so that there is no discrepancy during collection. The variables are usually of either qualitative or quantitative variables. And when we say qualitative versus quantitative, these are very, very important when you understand the statistical tool, because you have to write in the method section that these were the variables and they were compared using these tests. So when we say qualitative, which is also called as categorical, they could be nominal or ordinal. Quantitative could be discrete and continuous. Nominal categorical data means like gender, blood groups. Ordinal means where you can put them into some orders. There are some ordered categories, right? For example, say severity of or the staging of cancer as 1, 2, 3, 4, or Kuposwami's socioeconomic status, or the age when they are grouped as child, adult, and old. So these follow some orders. On the other hand, when we say quantitative, discrete means there is no value between two numerical values here. For example, TLC count. Either it would be 1001 or 1002. There will be nothing in between. Number of assessment acts, either 2 or 4, 2 or 3. There could be nothing between 2 and 3. But there could be some variables which will be continuous. For example, height, weight, age. For example, height, some may be 5 feet, 6 inches, or 5 feet. So somebody 5 feet, 3 inches. So there will be always, some will be between 5 feet and 5 feet 1 inch. So this means there will be some variable in between. So they are almost a continuous variable, and that needs to be taken as continuous numerical variable. These variables can be interchanged into from quantitative to qualitative sometimes based on, for example, when we say age, which is a continuous parameter, but if you group them into a child, adult, or old, you are making them numerical to categorical. So this is how you can do it. Now, when we say statistics, we have a good Excel chart where we fill up all data, but that does not make any sense. So we have to reduce those data so that we can understand, and that is what I mean by statistical. We have to summarize the data and then compare them using it. Now, the statistics could be descriptive. Descriptive means we are just describing or summarizing the data. Inferential means we are taking some inference out of the data that we have collected, whether one is better than other, one is inferior than other. So that becomes the inferential statistics. So descriptive, where we summarize them, mean of this group of population was suppose this. So we have just described them into one thing. Otherwise, we have 40 to 50 ages. We do not know that what was the mean age. So we just say that this was the age. We are not able to make any decision. On the other, inferential, we are going to make some clarity that yes, in group A versus group B, the age was comparable or the age was better or poorer. The statistical analysis can be either univariate, bivariate, or multivariate, depending upon the type of variables that you do. Univariate means where you categorize them that 20% were males, 30% were males, or something like this. Quantitative means you summarize them into mean and median. Now, this is important because sometimes we want to use mean or median. How to differentiate between them? It depends upon the distribution of data. Now, this is a normal bell-shaped curve. This means the data we have collected is normally distributed. It's not skewed to one side, something like this, or either the left side or the right side. So the center one would be symmetrical, and the right and left would be the skewed data. The symmetrical data is considered to be a robust data. This means there was no bias into a study, and the data we have collected was appropriate, and we can use the appropriate test. In the bivariate analysis, you compare different type of data, categorical versus categorical. We have already discussed these variables, so they can be compared into various formats. Now, when we say statistical comparison, or which tool will you use, if you can remember for prerequisites, you'll be able to say that this has been compared using this test, which is not need to be mentioned into your method section. How many variables, whether the data was normal or not normal, how many groups into your study, and whether your data was related or non-related. Related means you've done some intervention and then measured some variable in the same patient. So whether they were related or non-related. So based on this, you can do various statistical analysis, normal, not normal, groups, or related versus unrelated. So based on this, you can pick up your statistical tools, which we can discuss sometime later in an advanced discussion, and that is needs to be mentioned in your study. Sometimes we do a quantitative versus quantitative data, which are usually in the ICU setups, and they gives us some coefficient that if one increases, what happens to other, whether there is some positive correlation. The chances of mortality is higher if the length of hospital stay is much more. So this is how you can have some correlation between these, and that is what we use as correlation for analysis. Now, coming to these two terms, p-values and confidence interval, this is again a very upcoming important topic we need to mention. Most of the time when we summarize our data, we mention about the p-value. But p-value is not giving us anything about the whether the group A is better than B or not. This is just giving that the chance of occurrence of this difference between two groups is this p-value. So what we need to add on is that some interval needs to be mentioned in the two groups that will say that the actual difference of something between two groups was actually there, or the observed value was having some difference with the true value. And this is what is the confidence interval. In confidence interval, we mentioned, for example, you have a mean standard deviation of say 14 plus minus 3. So we'll give a 95% CI, that 95% of CI, 95% of the ages in this group will be between this, say 8 to 16. So now that 95% of population will be between this group, between this range. And this is what is nowadays required for the confidence interval. Now coming to the last couple of slides now, when we say the analysis, now sometimes we are so excited to exaggerate our analysis by using multiple testing or using different tools, and that creates an issue here. Now remember, whatever the p-value is, the statistical significance does not guarantee clinical significance, right? So even if you get a p-value of 0.01, it is not always guarantees that the clinically relevant difference is also there. For example, let's see this example. Time taken for tracheal intubation using CMAC VL was significantly lesser. You can see the p-value is 0.01. But let's see the data. The difference between was 14 versus 18 seconds. So for a normal airway with normal lung, difference of 4 seconds may not be of any clinical significance, but the p-value is significant here. So this means if you get some p-value which is significant, don't conclude that this is better than this. Always try to look for the clinical significance also. Similarly, I just mentioned about the confidence interval. Same example I will take. We have a time difference of 14 versus 18. Let's see 95% CI here. Now, if you see the 95% CI here, though p-value is again significant here, 0.01, but if you see the 95% CI, the values are overlapping. In one, it is 12 to 18 seconds. In second, it is 14 to 20 seconds. So this means your study is inconclusive. You are not very sure whether CMAC has actually lower time than the glide scope because your confidence interval here is overlapping. Even though your p-value is significant, still your conclusion would be the study remains inconclusive. So this is what is the understanding of mean, 95% CI, p-value, and clinical significance that needs to be taken care of. Another important thing is multiple testing. Sometimes we try to do a subgroup analysis of the patients. So again, if you try to dredge your data multiply, you will get something which is not desirable. Because I said your study was RCT, it was a two-group study, so that subgroup analysis sample size was not appropriate. And that's why when you try to do a subgroup analysis, you may get a statistical significance, but that is not warranted, and this is called data torturing. So this should not be done into your study. Even if you try to apply multiple tests, right? Because we say we have accepted, if you remember in the beginning, I said you have accepted alpha of 5%, that is 0.05. So 5% error, you have accepted it. But if you try putting up multiple testing, this 5% error increases. And that's why we have accepted 5%, but multiple testing has make it multiple times more. So this means this is not acceptable to us because what we have planned is not being done. And that's why multiple testing is not desirable. Now, coming to the last slides, at time you have to put up this protocols for submission for proposals. Be sure that the proper approvals has been taken from various agencies. The ethics approval, clinical trial registry, if you are using a new drug from drug controller, if you are using some radiations, bioatomic research, if you are doing outside hospital, outside the country, the health ministry screening committee, and also the adverse, the data and safety monitoring committee or board of your hospital is required. Equally important will be the trial registration. This has now become very important because your publications will not happen if you don't register them. You can publish in any public accessible website. In India, we have CTRI where you can publish it. Internationally, we have almost more than 12-13 registries. Similarly, will be clinicaltrials.gov from US. So you can publish in any of these registries. So that will be a very, very useful tool for you. And once your study has been done, you want to publish them for. So always remember that the publication goes through various channels. You submit it, editor revise, they are sent for peer reviewers, you get some decision and then publish. So when you are sending them for this publication, remember that all journals will have some format. So you need to follow the format. This is one. Second, whatever we have discussed in the method section should be reflected into your manuscript also. And all details must be there, specifically the method section, which is one of the commonest reasons for rejection of your study. So try to replicate or put up the points in such a detail so that anybody can replicate it. And each journal follows some instructions. So you can go onto their website, look for the instruction to authors, and try to submit in this format only. For helping you, just the last slide, there are certain reporting guidelines, and you can use them even for your protocol preparation. For example, the RCT, you use the consort guidelines. So it will give you certain points that must be part of your study, maybe protocol, and definitely during publication. So this will help you depending upon the type of study that you are doing it. For example, RCT consort, for observation, it will be stroke, for meta-analysis, it will be Prisma. So whatever study is, just go through this website. These are important websites and they will help you that you are not skipping or missing something during your initial protocol development or your sending for publication. You need to include all the points. If they are not possible, you need to justify that. So to summarize, a well-planned, a well-designed study is the foremost thing. You need to spend more time on the planning of your study and designing of your study rather than data collection and its publications. And if your designing and planning is good, the chances of acceptability and repeatable outcomes are good, and chances of its publications would be very, very high. So thank you so much.
Thank you very much, Dr. Rakesh, for the wonderful talk. Sir, we have one question from Dr. Vandana Mangal ma'am. She wanted to ask you that you say not to be a copycat, but we are asked to produce a seed article even for sample size calculation.
Right, I think this is an important question. I know this is a problem at many places. At many ethics committees have some issues. The issues are primarily concerned with the safety of the patient. So when ethics says that bring about a similar study so that they are sure that this is being done. So I'll put it this way. If a researcher is able to justify the research question, the objective, and the safety of the participants. So when I say, when you have to submit the protocol for ethical clearance, if you can clarify these situations, the chances of the seed article will not be required. Second thing we need to understand is, if you're thinking of absolutely something novel, right, which has not been done earlier. For example, you have things that there is some new chemical or new molecule you have thought of, which has never been used. We should be aware of that what should be the phases of study. You cannot directly go for doing a phase 4 trial for this study and try doing RCTs because nobody has done it earlier. So this means understanding of research for implication as safety to the patient or the participants is paramount. If you think, for example, say dexmedetomidine, you want to look for the analgesic efficacy of dexmedetomidine as an adjuvant for the anesthesia induction. We know that dexmedetomidine has been used for particular group of population. It has been approved for sedation in ICU. It has not been approved for using in the anesthesia induction as of now till date. So we should be cautious that we need to clarify that whether this is safe, there will not be side effect. This is being used for the first time. This is over the counter. This is unapproved off-label drug. So those all clarification must be there in the protocols. And obviously, I do agree. Some of us who are part of ethics committee needs to understand that the abstract replication of a study is not desirable. So when I say the copycat or replicability, I'll just give you some hints. So when say they need a seed article, I put it in a very positive way. If some say, can you show us a seed article? So when you read an article, if you see the last paragraph of those discussion section by the author who has done that study, they will put some limitation in the study, or they will put some future research. They will say that probably we have used 50 micrograms as infusion. This has created more side effects. So we propose that more studies are required on a lower dose. So this is giving a hint. So why do we want to use 50 micrograms? We can come with 35 micrograms. Now we have a seed article which has been done, which would also say that safety of the drug at lower dose is good. So we have got some novel protocols, novel research question. We also have a seed article where they have used in a similar way, but we are using in a different dose. So it becomes a novel article, a novel study for you.
Okay. Thank you, sir. Thank you for the nice explanation. And it's not only going to help the researchers, but also it's a nice hint for the ethics committee members. Thank you, sir. This presentation will be there on the group forever, and people will be asking questions on the comment section there.
Thank you so much. I will be trying there. Thank you. Thank you, everybody.